Hey, good afternoon, everyone. My name is Anne Wong with the Illinois Chapter American Academy of Pediatrics, and I thank you all for joining us for today's webinar on influenza. Today we are joined by Jennifer Burns from the University of Chicago. Before we begin, I would just like to go over a few housekeeping items. Phone lines are muted. This webinar is being recorded. If you have any questions for our speaker, please enter them into the control panel on the right-hand side of your screen, and Ms. Burns will answer them at the end of her presentation. Everyone will also be receiving a copy of the PowerPoint slides in their email, as well as all of the other things that I mentioned earlier. So I just want to reiterate, in case anybody has questions later on about whether or not they will be receiving a copy of the slides, the answer is yes, everyone will be receiving a copy of the PowerPoint slides. So I would now like to introduce Jennifer Burns. Jennifer Burns has an RN, MSN, CPNP, and an APN. She attended Loyola University of Chicago and is a certified pediatric nurse practitioner currently working at the University of Chicago section of pediatric infectious diseases. Jennifer has broad pediatric infectious disease experience, including the diagnosis and treatment for CA-MRSA, as well as other serious infectious disease conditions. Her clinical practice focuses on providing pre-travel vaccines and counseling to families with infants and young children who will be traveling internationally. In 2009, she started the university's Family Flu Clinic, where over 6,000 people were immunized. She's a member of the National Association of Pediatric Nurse Practitioners, NAPNAP, and the Sigma Theta Tau Honor Society. Please join me in welcoming Ms. Burns. All right, Jen, I'm going to turn it over to you now. I think you're currently muted, Jen, so if you want to unmute yourself. There we go.
Yeah, I am now unmuted. I tried to do something. I think you did it for me, Anne. Thank you very much, everybody, for taking time today in this busy season with getting school compliance together and, of course, doing our influenza vaccines. It's a very busy time of year. Please feel free to type any questions in, and I hope we can stimulate discussion about our going into our flu season. So our objectives for this webinar are just summary of the updates from the Advisory Committee on Immunization Practice. And I always like to say ACIP, and I take this point to want to bring up there's two licensing factors here when we're talking about immunizations. Immunizations get licensure from the FDA, the Food Drug Administration, to market their drugs, and ACIP helps augment the recommendations of those vaccines. So as we are clinicians and providers and we'll look at the box and read the prescribing insert, sometimes we'll see different recommendations from the FDA to the ACIP, and that's because our ACIP is a overriding governing body of practice, because they make some changes that help us give more vaccine, or we've seen complications, or like to change things. For example, I always bring up MMRV, the measles, mumps, rubella vaccine. We try not to give this as a first dose to infants because we did see after studies that there was more fever in infants. So we recommended just a single MMR and then varicella. So these are just differences in practices that we can see. Other impact of influenza disease that we're seeing in the community, talking about LAIV, which is the flu mist, pediatric vaccines, and egg allergy recommendations. And there's some new products that are available for 2017-18 and focuses on changes of recommendations in the new products. Vaccinating high-risk populations, and there's a continuing focus on pregnant women. And then always we like to make sure we talk about us as healthcare providers getting flu vaccines for ourselves. So in terms of updates for 2017-18 from the Advisory Committee on Immunization Practice, reaffirms that our FluMist LAIV should still not be used. And you can actually go online and look at ACIP minutes and PowerPoints about different slides that they're presenting. They divide it up in two sections, adult recommendations and infant, children, and adolescent recommendations. And you can see the presenters show data about different immunizations, different things that we're seeing. And what happened was we saw that in 2014 to 15 and 2015 to 16, I could be off with my years, but as soon as the product went quadrivalent, there was decreased efficacy of the vaccine that had never been seen since its initiation. So that's why it was pulled. We're always looking for vaccine effectiveness when we're marketing flu vaccines or any vaccines, and if it's not found to be effective, we don't want patients to receive it. So my other point to bring up about this is that they just met last week, about October 26th, and they reaffirmed they didn't want this used. The company MedImmune FluMist has studies from other countries that they presented, but they're not finished with some studies done, and they want those studies before they would allow the vaccine to be used. So most likely we're not going to be using this product at all this season. But you can look up the discussion points will be available shortly. They're not there yet, but they all voted on these different requirements. Now, a vaccine age requirement change. So Fluvaval, which is quadrivalent, changed its age indication, and we'll talk a little bit later about that. And then an ACIP recommendation change about Afluria, where it's licensed for 5 and above through the FDA. ACIP had changed this to be 9 because they had seen some more side effects with the younger kids receiving it. And now they're going back to the that license recommendation, and I'll talk about that again. And then just reiterating, pregnant women at any stage of pregnancy, trimester, can receive any licensed, recommended, age-appropriate influenza vaccine. Other new products for individuals 18 years of age or older are Fluria Quadrivalent and Flublok. And we'll talk a little about that later. Reminder for people that there are 3 different types of influenza types. Type A is the one that causes the moderate to severe illness, affects all age groups, and typically infects humans, some animals such as pigs and birds. So our H1N1 virus, influenza virus, was really, when it first came out, called Mexican flu. And then we said, well, no, let's not call it that because that's not culturally competent. Just like Spanish flu in the early 1900s, we switched it to swine flu, which this virus did come from a swine to a human, and humans transmit it to everybody else. So we do know that we can have pigs and birds transmit flu virus to us. So we're constantly studying that. In terms of type B disease, it's a milder form than type A, and it primarily affects children. And this virus only affects humans. And the types of influenza B are broken into 2 subclasses, Yamagata or Victoria. And these were really seen in the mid-late 80s circulating, and a lot of the flu vaccine companies have always had one form of B in it. However, there could be an influenza B mismatch because only one circulates in the air. So this is why most of the products have tried to go quadrivalent to account for that mismatch that can occur. And then type C is really reported as a type of illness for humans. In most cases are subclinical, and it really doesn't cause a lot of illness. So we don't chase this type of influenza virus. Looking at influenza burden, and this is since 2010, this is a pyramid that any year it varies at the stage of disease that we have. Of course, in a year that we don't have a good flu vaccine match, we have higher burden of disease. But we estimate that we at least have between 9 million to about 36 million cases per year. And of those, about 140,000 to 700,000 are hospitalized. And annually, we'll have anywhere from 12,000 to about 60,000 deaths per year. So it's very, very significant, and it's one of the most common vaccine-preventable diseases that still has very high mortality in the United States and around the world. The impact of influenza, each year is a different year. They can cause yearly sporadic epidemics and sporadic pandemics. The last pandemic we had was in 2009. And want to just recognize that influenza viruses can either do a drift versus a shift. And when you have a drift, that just means the virus changes somewhat, and maybe our vaccine for that year will provide some protection. And when it's saying it's going to provide protection, maybe it's not totally going to prevent disease, but it's going to prevent those complications of necrotizing pneumonia, seizures, different things that can happen as a result of influenza. When we have a shift, this is when the virus hugely mutates and becomes an entirely new strain that humans haven't seen. And this, as a result of this, we see a pandemic. And that's what happened in 2009. On estimate, 5 to 20% of our United States population are affected each year and infected. And influenza can occur in all age groups. The highest risk populations, are increasing because we have more people with chronic diseases, but the highest risk are young children, our elderly patients, pregnant women, because they're significantly immunocompromised, people with asthma, diabetes, heart disease, neurologic conditions, renal disease, and liver disease. And then, as always, are individuals that have chronic compromised immune system. So people who are on immunomodulators for rheumatoid arthritis or Crohn's disease, different diseases like that are more susceptible to viral illnesses. So, impact of influenza. Last season, 2016 to 17, was moderate, and our peak was in February. If you would remember back to years before, we had peak around December and January. So you can never predict when you're going to have our seasonal epidemics. Hospitalizations, when you look at this, the majority were elderly and then very young, less than 4. And then if you looked based on epidemiologic data, there's about 65 people per 100,000. So significant. Deaths, when you looked at the past peak of the epidemic throughout the season, it was anywhere from 8% to 10%, and with the peak, the highest week being 8.5. And then pediatric deaths can range any season between 34 to 171, and last year we had 95 deaths, which is significant. You can look this data up on the CDC. It's called the Flu Tracker, and you look at the regions, and I believe we're either region 5 or 7, and it will tell you exactly the peak for weeks. So remember, I believe we're in week 43 right now, and it's counting down to week 52, and then at the beginning of January it'll go to week 1, and you can see just with the chart how it looks, and then they'll break it down to what actual influenza virus is circulating. We do have circulating disease right now. I registered for the HAN, which is the Health Alert Network, and you can see they'll send you what's circulating, what's peaking, what's not. We do have some H1N1 disease circulating, H3N2, I believe, is circulating, is leading right now. But that could change as we hit our peak. But we are tracking that as best we can. So far, the vaccination is the only way to prevent illness and the complications associated with that. So when we look at the economic impact of influenza, this is adults. We estimate there's medical and indirect costs annually about $16 billion. That's huge. When we look at the children, we break that down of caregivers of the children seen in the hospital, ER, or outpatient, how many hours work has a parent missed, the cost estimated from work, out-of-pocket costs, and total medical costs. So obviously the hospitalized child is going to have the most deficits because it's a lot of work is being missed, about 2 weeks, and about $1,500 out of your pocket. Excuse me, estimated cost with work is $1,500, I would say, if not more, plus the stress. And out-of-pocket costs about $200, and then Medicare total costs, of course, $4,000, and that's if we have a good outcome. You don't care, but you'd really like to prevent any complications. Emergency department visits, half a week of work. So this is significant. It's not without financial implications, plus it's not even quantifying the stress that can happen. So here's our influenza vaccine recommendations. We've had a universal recommendation, meaning anyone greater than 6 months of age living in the United States should receive the influenza vaccine unless medically contraindicated. So the only contraindications that we know of are history of severe allergic reaction to any component of the vaccine. Now, egg is excluded from that, and we'll talk a little bit later in the presentation about that. Timing of flu vaccines. The flu vaccine season, excuse me, is October to May. The peak can happen in December, between December and February. We do know that it takes about 2 weeks to make antibodies once you have received the vaccine, and so it's recommended as soon as a vaccine is available, offer it, and no later than October. Of course, we're going into November, so if you're seeing your patients for the first time because they're here for physicals or what have you, get it into them, because getting it into them is better than not having it in them at all. And remembering to offer vaccines during all healthcare visits and hospitalizations whenever it is available. And I like to vaccinate throughout the entire flu season because people travel, and when they're traveling in the southern and the southwestern, southeastern parts of the United States, influenza can circulate all year at a higher rate than it does in our geographic area. So I use my vaccine until it expires, and then I'm without vaccine until the new shipment comes. Types of vaccine. So we now use the nomenclature IIV to stand for inactivated influenza vaccines, and we have 2 different types of inactivated influenza vaccines. We have TIV or QIIV. TIIV or QIIV. So one is the trivalent, which has the 2 A's and 1 B, or the quadrivalent will have the 2 A's and 2 B's. Now, the second one is a cell culture-based flu vaccine, and it's just a different way of manufacturing the flu vaccine. So it's CCIIV4, meaning cell culture-based inactivated influenza vaccine quadrivalent. And then recombinant inactivated flu vaccine, quadrivalent versus trivalent, those vaccines are going to be completely egg-free. And then for individuals 65 and older, there's some high dose, which is either quadrivalent or has an adjuvant added to it to stimulate flu immunity. And then LIV right now is not, was previously available, but it's not recommended. So I talked about this. LIV should not be given. The CDC and the ACIP conduct the vaccine effectiveness studies, and there it is. It showed from 2013 to 2016 it had significantly lower effectiveness than it had in the past. Reason for the poor performance is truly not known. ACIP continues to review the data. They think that when they went to quadrivalent, it changed the way the vaccine binded and conferred immunity. And the company also said, well, I think it's a storage issue as well because it's highly unstable. So it was just interesting. You can see the data that's presented. In terms of the ACIP recommendations for pediatrics, children between 6 months and 8 years, if they've never received a flu vaccine, should, in any season, should receive it greater than 2 doses of flu vaccines. Okay, so let me clarify. If children receive greater than flu vaccines prior to July 1st, they're only going to need one flu vaccine this season. If we're unsure, then they need 2 doses 4 weeks apart. If they've never received a flu vaccine, still 2 doses 4 weeks apart. And there's great data to show that kids need to have this boosting in order to have good effectiveness for future flu seasons. This is a nice, simple algorithm. I like to put this up in my room, so I tell the parents, and we go through it together, and I walk them through why, if they're unsure, and I don't have their data, I'll give them 2, because I'd rather be safe than sorry. But this is the nice thing to have. You know, has a child received greater than 2 doses of trivalent or quadrivalent flu, it doesn't matter which one, and it does not have to be received during the same season or consecutive seasons, okay? So, yes, they only get 1 dose. No, I don't know if this is the first time I've ever given my kid a flu vaccine. Then you need to give it 2 weeks apart. Egg allergies. ACIP recommendations for this. RIV, the recombinant influenza vaccine, Flublok, or RIV Flor, is completely egg-free. So this is the only vaccine that's completely egg-free, but it's only available for people 18 years of age and older. However, we as clinicians don't need to worry about egg allergies. Anybody can receive any flu vaccine, but for those with egg allergies causing hives, we don't need to watch them anymore. They're fine. But for those with severe egg allergy, they need to get a vaccine by a healthcare professional in a setting in which they can provide emergency resuscitation. Now, of course, if they have total anaphylaxis, hypotension, and so forth, which is documented in this next slide, then these are individuals that we're not going to give flu vaccine. Okay, so if we go through the slide here, after eating eggs or an egg-containing product, does the patient experience only hive? Yes. Go ahead and give them any product. But after eating eggs or an egg-containing flu, does the patient have any other symptoms, like cardiovascular changes, respiratory distress, GI issues, reactions requiring epinephrine? And you click yes. It's really important to put them in a setting in which you can provide other settings. So most providers would say, I'm sending this kid to immunology or allergy to get this vaccine, and that's very appropriate, okay? So that you can really do this in a very controlled setting as opposed to being in a clinic where you didn't have another area to transfer this kid if they required more. I haven't seen much of this, but a lot of times if I'm in doubt, I have an allergist and immunologist that I can work with that helps me. Influenza vaccine production. So here is our trivalent stains. It has a H1N1 pandemic-like. It's a A Michigan. And then we have an A3N2-like influenza virus has really come from Hong Kong. And then B is in our trivalent, which is along the Victoria lineage. And the only difference between the quadrivalent versus the trivalent, it adds the Yamagata to the vaccine. Quadrivalent vaccinations addresses the possibility of the mismatch for B. The available formulations are an inactivated influenza vaccine, the culture cell-based types, they're in the recombinant. And just to remember, there's no preferential recommendation to use trivalent versus quadrivalent. It's really up to the practice to decide what vaccine is going to best fit all of the practice that they're going to be seeing, okay? So that's very important to consider because vaccines are expensive, and we want to make sure that we're, at the end of the flu season, we're not throwing out money in the garbage, right? So that's very important. So again, the choice should be driven by the age, indication, and contraindications and precautions. No preference for quadrivalent versus trivalent versus high dose versus standard dose versus inactivated and flu vaccine versus recombinant. It's really the provider's choice. One thing I will say about the recombinant vaccine, and I have to check this. It had a shorter shelf life, meaning it would expire quicker than our typical vaccine. So you really do want to make sure if you do get some of the recombinant vaccine that doesn't have any egg in it, that you really order what you need because it will expire sooner. And it's very important. You don't want to spend money and not use a vaccine. New in 2017 and 18 season, age requirement change. And so we're going to go over that and the ACIP recommendation on Afluria and our new products. So Flu/Laval is a quadrivalent vaccine that had really been indicated for over 3 years of age to the oldest person you could immunize. And what happened is they went and got approval to allow this vaccine to be given down to 6 months of age, which is really a nice option for us clinicians to really try to carry one vaccine stock and to help reduce errors. It's made by the ID Biomedical Corporation, and this age indication was expanded in 2016. The infants can receive the same dose, which is 0.5, as used for older children and adults. And this would be the second vaccine available for our pediatric patients between 6 months and 35 months of age. The only other vaccine before this was Fluzone by quadrivalent. So again, it's a nice option because for me, it's primarily doing a pediatric family flu clinic. I can have one vaccine and not worry about grabbing different stocks. So that's important for me. The second change is regarding Afluria. So Afluria had different age recommendations from the ACIP versus the FDA, and we talked about that. The vaccine Afluria was originally licensed for persons greater than 5 years of age. But in 2010-11, ACIP changed it to over than 9 years of age because they found from the VAERS system, VARES, Vaccine Adverse Event Reporting System, that there was an increased amount of febrile seizures and reactions to this vaccine. So they brought that back to the company and said, we're changing the age because we see 9-year-olds 9 and up didn't have this problem. So the manufacturer went back, investigated the cause, and then changed something in the vaccine and did another study which showed it had a better change the safety profile. So the ACIP changed it back to 5 years of age and older. So this is how committees are working together to make sure vaccines stay safe for us. And then Afluria quadrivalent is a new product for over 18 years of age. It's by Seqirus, licensed by the FDA in 2016. Licensed for persons greater than 18 years of age. I would like to see this go lower. They have a needle or syringe, or you could use the free injection system. That's what I'd like to use. So this is a different system. I actually haven't used it, but I've seen it demonstrated. You do have some local site reactions more commonly compared to Afluria, but low overall. But a needleless system, maybe even for adults, would be nice as well, but for the pediatric population, it would be nice. And then another new product, again, for individuals over 18 years of age is Flublok quadrivalent, and this is by Protein Sciences. It was licensed in the FDA in 2016. Persons greater than 18 years of age is an IM injection. It's egg-free. And then the most common reactions are injection site reactions with tenderness and pain. This is our influenza vaccines for the season of 2018, and as you can see, it's kind of complex. I do sometimes have these up in patients' rooms because a lot of times I'll get questions from patients about thimerosal. Is this preservative-free? And if you're ever using a vaccine that's just coming from a syringe, it's always usually preservative-free. It's the multi-dose vaccines that have preservative because it has preservative to prevent people who are going to keep the vaccine effective. It has a little preservative in it. And then other things that people have to worry about are latex, and so this tells us about that, and age indications. So it's a helpful sheet. Again, this is another influenza vaccine product list. The nice thing about this is it tells you the manufacturer, it tells you the age group, and then there's some product billing codes, CPTs, and Medicare billing codes that people may need. So this could be more helpful for our billers and coders. The other things that we need as providers now are NDC codes or medications, and that would be nice to see. So in terms of vaccinating high-risk population, that's the next section we're going to move on to now. And the first group we're really going to focus on is pregnant women. Again, we want to make sure people know that pregnant women may receive any influenza vaccine, not limited to IIV. Any licensed, recommended, and age-appropriate trivalent or quadrivalent IIV or recombinant influenza vaccine may be used. And they receive the ACIP reviewed information presented by the manufacturer and all the documents by this and found that it was safe. And it's very important, especially for our pregnant women, because people don't realize that, you know, pregnant women are immunocompromised and they're walking around. And they're 4 times as likely to be admitted if they get flu compared to non-pregnant women. And they are also 50% more likely to have premature labor or some complication to the fetus that can be very harmful. We do know that flu is harmful for the developing baby. And if women in their first trimester to second trimester get fever, we know that fever and increased temperature increases neural tube defects and other adverse outcomes. So we're really pushing our pregnant women to really get immunized. So strong recommendations from all of our providers is crucial. Vaccination is appropriate in any trimester. Immunization of the vaccine passes the protection to the unborn child. And then vaccinate close contacts to prevent the baby from other exposures. I mean, I do this all the time with my child. I didn't let anybody come in the house. And now I'm getting ready to have a baby in February. I've never had a baby in the flu season, so I'm going to be like crazy and not let anybody in. Reminder on postpartum women, they can receive any flu vaccine. The postpartum women should be vaccinated if not done during pregnancy. And again, they can receive any vaccine. And breastfeeding is not a contraindication. Breastfeeding passes on maternal antibodies. Now the next chronic illness that we're going to focus on is vaccinating individuals with asthma. And then people with asthma, influenza can trigger asthma attacks, cause further inflammation and irritation in the lungs and the airways, leading to pneumonia and other respiratory illnesses. So individuals with asthma should get the flu vaccine as soon as possible. We should make sure they're up to date with pneumococcal vaccine, make sure they have an asthma action plan and correct medications prescribed. And if they're infected, we're recommending not to provide zanamivir, or otherwise known as Relenza, because it's found to cause wheezing. So also tamivir is the drug of choice for our asthmatics. The next population is children with neurologic disorders. And we saw in 2009 that these individuals, about 2/3 of the children who died from H1N1 in 2009 were people with cerebral palsy or intellectual disabilities. So I would like to always remind people that anybody with neurologic disorders aren't necessarily are physical things you could see. There are people with seizures, there are people with some IQ issues, and they had severe complications with influenza, with mortality, and then they lost some IQ points as well, or lost ability to do some activities of daily living that they had before. So we do recommend this group really gets it. If we do identify that or suspect that they have influenza, we need to treat early with antivirals and be aggressive. The other groups who are at risk for complications, children under 5, especially those under 2, pregnant women, asthma. I've talked about the neurologic individuals, chronic lung disease, heart disease, blood disorders, endocrine, kidney, liver, metabolic disorders, weakened immune system, children and teenagers on aspirin therapy. You know, a lot of people can't be on aspirin therapy for preventing of clots, or I'll have kids that have Kawasaki disease or congenital cardiac problems that they're on aspirin. So it's very important to vaccinate them. In terms of our healthcare personnel vaccination, this is a slide. When we look at the slide here, we see that individuals, here's the red line. We want to be at least at the red line. We still have about 30% to go. And this is the dotted line looking at different years that we've been immunized. And we notice that most of our healthcare providers, about 60%, try to get immunized during November. But then a lot of our healthcare providers are getting immunized in April because they're seeing that flu's hit and they're going to get their flu. So we'd really like to start immunizing earlier, October and November, and we do want to hit our Healthy People 2020 to be at 90%. So there's many reasons to vaccinate ourselves. I mean, I always like to put at the top of the list, it keeps me safe and keeps me working and makes me not be sick. And that's the biggest thing. But a secondary goal would be, of course, to keep my patients and other healthcare providers safe. It demonstrates confidence in the vaccination. It decreases my loss of work and lowers my healthcare costs. It's recommended. And then some, institutions, it's required. Most institutions should hopefully provide this free on site. And some employees actually require it. So just to give us some summary of our updates, in terms of the ACIP, FluMist should not be used. We have an age requirement change with our Flu-Laval. ACIP changed the age of Afluria back down to 5. Pregnant women can receive any influenza vaccine that's age appropriate. And new products for individuals that are over 18 years of age are Afluria and Flublok. So I'd like to this concludes our program, and I would like to thank you for your attention. And I'll turn it over for some questions. And do I have to give you the screen back?
Okay, thanks, Jen. So, okay, now I'm going to go over some of the question and answers with everyone. So, Jen, I'm going to switch it back to my screen. Okay, so it looks like the first question that we have is, many of my parents are refusing the flu vaccine because the nasal formula is not available. Do you think they will ever bring it back for use in children? I feel that some vaccine is better than none.
Yeah, I agree with you. I have to be, I'm very sad that we don't have our live attenuated influenza vaccine. The goal for FluMist is to bring it back. So, once we get the okay to use it, people can order it. They brought it to the ACIP late, right, in October, so I had ordered some myself, but then I realized, I'm going to be done immunizing. I'm not waiting to January, so I had to cancel it. And I'm glad I did because it's not still commercially available. So the goal of the company is to be bringing it back. They'll be presenting studies probably in February, hopefully. And I would suggest to the parents that, you know, if it was commercially available here in the United States, we'd give it to you, but it's not. So bear with us for 2 years to do the shot, because something is better than nothing. And we do have the data. The shot is better right now, and there's nothing we can do about that.
Hey, Jen, can you go back about like 20 seconds because the audio kind of cut out, and I just want to make sure that people hear your explanation a little bit better.
Sure. Let me see if I can recapture. So unfortunately, the vaccine effectiveness studies showed that FluMist for those 2 last seasons after they went quadrivalent were not effective, and the inactivated influenza vaccine was far superior. I do know the company is showing data to say after they've changed the way they've manufactured its vaccine, it's better, but they don't have the one study that the advisory committee wants. They don't have that data back. So the vaccine's available in other countries. So I'm hopeful that they'll be bringing it back to the United States. So my recommendation to people is have patience. Right now, this is the most efficacious vaccine we have, and I really want to protect your child because something is better than nothing.
Yeah, I mean, I think especially if the strong push that we had, it's a little bit of, you know, I think it's a hard pill for some parents to swallow. But so the next question that I have is there benefit for HCW to defer flu shot to October to ensure vaccine lasts the entire season?
I'm always a big push is get it as soon as it's available and before everybody starts getting sick. There's no, I mean, we know that it takes 2 weeks to work, and we know on average the flu vaccine is effective for anywhere between 2 to 5 years. So I'm always get it as soon as you can because we get busy and then we forget. So do it.
Okay, so I'm not getting any more questions, but I'm going to go ahead and just start reviewing like the closing notes, and then if anyone does have any questions additional, please enter them into that control panel that is on the right-hand side of your screen. So we have one last webinar coming up to wrap up our 2017 immunization webinar series. It's actually another webinar on the flu, but we're hosting this one during National Influenza Vaccination Week, and that one will take place on Wednesday, December 6th, 2017, same time as usual, 12 to 1. And we'll have Dr. Angela Campbell from the Centers for Disease Control joining us for that webinar. And everyone can register at that link that they see below. We'll also be including this link again into the email that I'll be sending everyone afterwards. And then after this webinar, everyone should be receiving a copy of the PowerPoint slide, a link to complete the survey and evaluation, and also a link to the recording of the webinar by the end of business day tomorrow. You must complete the evaluation by November 22nd, 2017. After this date, the evaluation will be closed and you will no longer be allowed to fill out the evaluation or receive a certificate of attendance and/or continuing education credit. Everyone should also be receiving a copy of their certificate by November 29th, 2017. So it looks like I did get a couple more questions while I was going over that, so I'm just going to go read it out really quickly. So so somebody just wants a reiteration of if the flu vaccine is effective for 2 to 5 years.
So typically from studies that we've seen that each year that flu vaccine, the immunity towards it should last anywhere from 2, the longest would be 5 years. So those are some studies that looked at immunogenicity data. And that's all I really have on it. But no matter what, we still are recommending yearly vaccines because we don't know who's going to always respond or who's not going to respond. So that's why we recommend yearly vaccine. There's some data in the pipeline looking at getting one flu vaccine that'll cover all the flu viruses that are found, but we are about 15 to 20 years away from that technology right now. So I've heard some basic science talks about that. But we do know that one flu vaccine typically should last no longer than 5 years. So we don't know how the average person always responds, so that's why we recommend yearly flu vaccination recommendations.
All right, great. So I think that just about wraps up our influenza webinar. Thank you so much again, Jen. That was very informative as usual. You definitely know a lot about influenza. So we look forward to everyone who will join us again in December for our final webinar of 2017. And then just to reiterate, everyone will be receiving their email by the end of business day tomorrow. So thank you so much again to everyone for attending, and to you again, Jen, for presenting.
Thank you. And just as we're going into the holiday season, your travelers, get them immunized, because nothing like a holiday season but spreading flu. So keep everybody safe during the holidays. Thank you, everybody. Have a good afternoon.
Thanks.